Hi, everybody, and welcome to the Mind on Mental Health podcast. My name's Andy Dean. I'm a licensed clinical social worker. And today we're actually switching things up a little bit. I'm actually the one who's going to be interviewed today. And I'm being interviewed by Pete Maclearie, who is the site director at Princeton House Behavioral Health's Eatontown site. The reason why I'm being interviewed by Pete is because I recently wrote some psychoeducational curriculum for them to use in their new anxiety and mood disorder track in Eatontown, New Jersey, since I specialize in the treatment of anxiety disorders in my private practice. So I hope you guys enjoy the episode and find it helpful.
In your experience, does that extend, like, do you care whether someone has OCD versus like GAD, or like you would kind of approach it?
There are clinicians out there that think OCD and GAD are pretty much the same thing. I don't know if I'm quite there, but it's similar. So like OCD is like that obsessive worry followed by the compulsion, which is some kind of compulsive behavior to make that feeling go away. GAD, I think the main feature of GAD is basically like worry. And if you think about it, there's not much space between an obsessive thought and worry. It's just like, it's that thing that your mind tries to pull you toward to get you stuck in that loop, right? To think about nonstop. Some features of the disorders are different, specifically like the compulsions in OCD, but largely I think obsessions and worry can look really similar. I don't know if I answered your question.
Oh, I mean, you definitely started. I think some of it is, you know, most people, I don't know if we totally covered it when we did our misnomer podcast 5 years ago, right? But we talked about like OCD versus OCD personality disorder and how there's like people misuse the term OCD to like label a personality and not the
particular
condition.
About something.
Right, yeah. But I think also too, like in trying to help people really understand the treatment that they may need, do you think that there's like a fundamental difference? Like, would you say you prefer more to treat like OCD, or are you more just like, hey, if you have this anxious content in your mind, it's kind of the same basket for you?
What do I like to treat personally? Is that what you're saying?
Well, more like, it could be you personally, but also just like with what you've learned, right? Like your kind of treatment style, does it need to differentiate or not really?
I don't think so. There are things you might do differently depending on the disorder and how it's kind of manifesting itself, but largely the principles are always going to be pretty much the same. So like, regardless of the anxiety disorder you're talking about, or OCD, since OCD technically isn't an anxiety disorder anymore, it's like categorized separately. The functions of what you want to do are the same regardless of if it's panic, social anxiety disorder, OCD, GAD. And what does anxiety want you to do if you have an anxiety disorder?
Well, it wants you to do something, usually.
Okay. It wants you to change your behavior in response to it, right?
Sure.
And it wants to be the most important relationship that you have, right? It wants to always put your attention on it. Largely, the treatment for that is going to look the same regardless of what anxiety disorder we're talking about. Does that make sense?
Yeah. So the other thing we haven't really got to yet is obviously you were trained, certified, correct me if I'm wrong, certified in ERP.
Correct. Yeah. Yep.
Okay. So
I don't know why. Correct.
So with that, like, does the ERP approach kind of, would you use that for both as much, or do you?
ERP is a specific therapy modality that the main tenets or principles of it, I think, can be applied broadly to anxiety disorders as a whole.
Can you do me a favor? Can you tell all of our lovely listeners what ERP is?
ERP stands for exposure response prevention. And the principles of it, or the tenets of it, I think, largely can be applied to anxiety disorders as a whole, which basically means we want to stop avoiding things that make us uncomfortable, and we want to go toward them so that we can build that muscle, our resistance to that feeling or thought, right? And we want to, so that would be the exposure piece. The response prevention piece would be, we want to stop doing the things that we're doing to accommodate the anxiety. So to make the feeling go away, or to make ourselves feel better because we might have an anxious feeling, right? So you can think of that as like safety behaviors versus compulsions, or just avoidance in general. ERP is the gold standard treatment for OCD, but the tenets of it, broadly speaking, I think can be applied to anxiety disorders as a whole.
Sure. I mean, my experience, obviously I spent a lot of time as a trauma therapist, and while I'm not certified, I don't use ERP, but that idea of asking my clients to not avoid traumatic stimuli, 100% I can agree with you that exposure is a wonderful gauge.
Tool.
And
Yeah.
of course. So you got certified, you kind of told us your story earlier. Is that what motivated you to pick like ERP to kind of really take your practice to the next level?
A few different things. Like I really love doing ERP with clients that need it because you see improvement so quickly.
But even before, right? Like, your time as a therapist working at Princeton House, I mean, we weren't doing ERP.
Totally.
How did you kind of even come to say like, that's what I want to go do?
Oh, well, I did it on myself for my OCD.
So it was like the whole, heck yeah, this worked so well for me. I want to.
Partially. And also I think that's something just that I wasn't as aware of when I was a clinician before.
Sure, yeah.
And it totally fits my personality in terms of a modality that I would like to do with patients.
Did any part of, either when you went through it yourself or when you went and got certified, did any part of it like shock you in like how effective it was? Or maybe a better question, how different than maybe your initial professional expectations were, being that you were a therapist? Because again, we're talking about this idea of like misconceptions with anxiety treatment. So like, what were some of the things that you were like, like, oh man, like I would not have thought that this is what I'm supposed to be doing?
Yeah, I guess there's two main things that I can at least think of off the top of my head. I thought it was really cool and something that I wanted to do, that the therapist oftentimes would do the exposures with the patient. I also, just the concept of approaching the thing instead of avoiding it or trying to make the feeling go away, and learning about how to do that in a therapeutic context was super interesting and exciting to me. Because again, you tend to see results so quickly if the person is willing to jump in and do it. And then the other thing that was really helpful for me as a therapist, and also in my own treatment, was just being able to recognize what mental compulsions are. Because like so many people, I oftentimes would think of compulsions as something you could see. Somebody washing their hands, somebody, touching something 3 times.
Yeah, sure.
Double checking the locks on their doors, right? Not realizing that, I think, oftentimes, a lot of those compulsions are happening up there, just to give you that quick hit of reassurance, right? And just how many different ways those mental compulsions can kind of present themselves.
And so just to clarify, when you say mental compulsions, you're saying, so this is not something that they're physically doing, they're just thinking about doing it?
Correct. It's not even that they're thinking about doing something necessarily, but this would be like, we're talking about OCD specifically here. This would be, I have the obsessive thought, of me reaching over and choking you right now. This is my favorite example when someone's interviewing me, right? And then I have the thought that goes along with that, what does that mean about me as a person? Does that mean I really want to do it? Oh my God, that's terrifying. What am I, some kind of homicidal maniac? And then I kind of train myself over time that, okay, I have this thought about me choking Pete, but if I tell myself in my head, no, I'm a good person, I have a family, I would never do something like that, I've never done something like that before in my life, right? So why would I do that now? Like, it makes no sense that I would lose control. Like, to kind of logic my way out of it. So my anxiety is spiked, and then if I can take it down by having that thought, whatever it is, to cancel it out, that's a mental compulsion. It's not necessarily that I'm taking an action so much as I'm having a thought. And I guess the distinction, or the thing that makes mental compulsions difficult to treat, is that it can become such a habit and so automatic. It's a lot it's much more difficult to stop yourself from having a thought than it is to stop yourself from washing your hands, for example. Right?
Yeah, white bear.
What'd you say?
I said white bear.
White bear. Yeah,
I got you.
Yeah.
Okay. No, I think that's really helpful because I think, again, a lot of people would assume, and I know you and I have talked about this, like if I get really anxious and then I pray and I feel better, it can be kind of the same phenomenon.
100%.
Right? Yeah,
that's
right?
a great example.
So,
and one that's frequently used.
Right. So how do you kind of approach telling someone to like not engage, especially because a lot of people take their spirituality and the strength they get from that as like a boon. How do you walk that back without treading
from a spirituality perspective?
Well, I guess like trying to take away what feels like a successful safety behavior.
Right. It's hard. We have to do a really good job at teaching them about how it works. And what they're doing that's keeping themselves in this cycle, right? And again, I would go back to intention. When you're saying that prayer, why are you saying that prayer? What's the attitude you're saying that prayer with? Is it because you had this thought that's disturbing or uncomfortable? Then maybe I would say, try not saying the prayer and just let that anxiety hang out until it naturally comes down on its own, right? But if you're saying that prayer because you say a prayer every night before bed, just because it's part of your routine, great. But if it's in response to the thought, then that could be compulsive. Did that answer your question?
Yeah, I think that's always such a hard thing to navigate.
It is.
Really understanding what's a mental compulsion. I remember, and I don't know if maybe your opinion on this has changed, but you had done a presentation almost 2 years ago about that idea of like pure O and like really...
Doesn't exist.
Okay, so have you changed your stance on that?
I don't. I could be wrong. I don't know what I said 2 years ago, but my stance was always kind of that they use that term pure O, which means obsessions only and no compulsions. I've never found that to be true. I've never worked with a client where that's actually the case, where they're not doing something in their head to compulsively cancel out the thought. It may not be as easy to spot as having a specific prayer you need to say, but it could just be like compulsively checking in on what my anxiety is doing, right? Yeah, I'm not a huge believer in pure O as a phenomenon.
No, I mean, I think even just trying to understand, for a lot of people, they might know they're anxious, they know certain things work, they know that they have these thought patterns, and it's really trying to help them understand like what you as the therapist want them to do. One of my next questions for you is, when you're trying to do an exposure and you're trying to help someone, let's just use like they're afraid of dogs. What do you do if in the exposure the person has a negative experience with the exposure?
With the exposure itself?
Yeah, so like in this case, like let's say the dog jumps on them and knocks them down, or God forbid bites them. Like how do you as the therapist handle like what you've tried to convince the person to do? What is that like?
What's it like for me personally and emotionally as a therapist?
Well, I mean, obviously.
Or how do you get the person back on board?
Yeah, how do you move
I
forward?
would say there's no way I would design, well, no, let me take a step back.
Take us through your thought process, because I could see you like,
Okay.
maybe the question's flawed, and the idea is like you don't put the client in that situation.
Originally, I was going to say, there's no way I would design an exposure where the person's going to get bitten by a dog and knocked down and mauled to death.
Okay, I wasn't going that far.
But I would probably pick a dog that's less aggressive. But then I thought, I don't want to give people that reassurance, because part of doing the exposure is probably that they have a fear that something like that might happen, right? So we would want them to go into the exposure knowing that that's a possibility, because it is a possibility.
Sure.
Even if I pick the nicest dog on the face of the planet, I can't tell you 100% that they're not going to knock you over or bite you. And that's kind of the point of an exposure. So like my goal, I would do a prep work with them and let them know the whole point of doing this is to make you feel uncomfortable and take the risk that something bad might happen.
Right. So again, I want to pick up on the point because I think a lot of times, conceptually, a lot of what you're saying makes sense. It's like, yeah, let's like build our tolerance to this stuff and like kind of break that barrier that like you can't, because we can. But one of the things that can get really tricky is like, you know, if you say to someone like, hey, I want you to go to a cafe and say hi to a stranger, a lot of people are on board for that, right? Because it's like the worst that happens is the person rolls their eyes at you or says, go away, weirdo, or something like that. And as the provider or the therapist, you can feel like, all right, we can work with that, right?
Maybe though, Pete, maybe that's easier. But for a person with severe social anxiety, they might rather get bitten by a dog than go have that experience.
I will defer to, I mean this, I will defer to you and your experience with this, because I was thinking more as the provider, like physical harm that I'm kind of like, or not ordering, but like kind of treatment planning feels like a no-no. And I think the idea is like, this is why clients can get really stuck, because the providers are like they feel a little handcuffed with like, well, I don't want to push you too far, like even contamination, right? Like I've seen ERP treatment where people are like jumping in a dumpster or putting their mouth on things that are gross, and your client could get sick, I guess.
They could, and they have.
And that's the idea.
They could, and they have.
Right.
And they could get sick, and people have gotten sick.
Yeah.
And that's kind of the point.
Right. But I think that's really like, again, you said a line to me the other day, and maybe this will spark your memory. Like you were talking about motivation being a key point in getting clients through this, right? Do you remember you were saying it's motivation, it's not motivation?
It's largely, I think, about discipline. The mistake that people oftentimes make, and I'm sure you've heard this in other therapy trainings, is they wait for that lightning bolt of motivation to strike. And then they're like, I'll go do exposure when I feel like doing exposure. But what's the problem? When are you going to feel like going to lick the doorknob or having that experience that you find really scary? My guess is never really. So I think largely it's about committing to it and discipline. That's kind of what I try to instill in my patients instead of waiting for the motivation to strike. The other point is that motivation is something that builds on itself. It's not this lightning strike or this bolt of lightning, then all of a sudden now I'm motivated to do the thing. It's more like, if I really don't want to do exposure today on a Monday, and then how motivated am I going to be tomorrow on a Tuesday to do exposure? My guess would be slightly more motivated to do it on Tuesday if you did it successfully on Monday. And then that's how we slowly build motivation instead of waiting for that lightning bolt.